own that has its own P&L and its own ability to create value. So when I think about delivery science, really it's like everything in this green rectangle here. So if I think about like the goal for all of us here is to help people become healthier. And the way to do that is by people, processes, and technology. So for those who are in informatics, I mean, these are kind of very familiar terms, right? I mean, everything is really people, process, technology, which often comes together to form a care model. And the digital technology, if we are implementing digital health, you can probably break down most, if not all, digital health tools as information that is valuable, that's helpful, that can be generated by maybe an AI model, or maybe it's simply generated by another person, or maybe it's sourced from some proprietary data source. Either way, the value created by a digital tool is often because the information in that tool is helpful, and you pair that information with a user experience. And then when it comes to AI, it's really how do you make that information useful using algorithms? So what I'll describe today is how we solved a specific problem in our health system using this framework to create a care model, a workflow, how we evaluated it, and then some of the theories we have around why it potentially was successful. So this work actually started years ago. So really appreciate the opportunity to still talk about it. We conceptualized, and also I know I'm speaking to folks from Kaiser who've been doing this before us. So this is not a new concept to use predictive models to detect deterioration. I think people have done this for probably more than a decade, or even more than 2 decades. So we knew that this wasn't the novelty of our work was not so much the fact that we used a predictive model. I think what we really wanted to focus on was how do we create collaborative workflows between physicians and nurses in such a way that changes the dynamics between the physician and the nurse, and how can a predictive model make that possible? So we actually talked about this when we first implemented this program back in 2022 in this New England Journal Catalyst paper. I'll just quickly go through how the problem we were solving and just some background. And I think everyone in this call are they all clinicians, Vinny, or should I go through some of the kind of more basic clinical concepts? Okay,
I think it's fine to go through. I think it's a mix. So go ahead and kind of give a little bit more background.
okay, sure. The problem we were solving at the time was that so I'm a hospitalist. I see patients who are admitted to the hospital because they are sick, and a lot of times patients get even sicker, and they have to escalate to a higher level of care, such as in the intensive care unit. Many times those events are unavoidable. You know, often if you have something called sepsis, a really bad infection, and your blood pressure drops, sometimes the infection is just that bad, and then you have to go to the ICU. However, there's evidence, and there's really kind of this way of thinking about escalation of care, in that there's escalation that you prepare for and escalation that you just did not prepare for at all. And as a physician, I can definitely attest to the times when a patient gets sick very quickly, and I probably should have discussed something with the nurse that morning when the patient wasn't crashing. And had I done that, probably would have been better for everybody. But because we didn't really get to coordinate early enough, um, that escalation was just a more difficult process for us to go through. So what we wanted to solve for was to prevent these unexpected deterioration events, things that happen urgently that we thought would lead to increased mortality in the patient setting. And we started when we first did this is back in 2020, actually 2019. This was before COVID. We were so we treated this as not an AI project. It was purely just a quality improvement project with the nurses and our physicians to figure out, well, why are we not huddling? Why are we not on the same page sometimes when patients are clearly getting worse? And we used standard process improvement methods to look at root causes. And it turns out that reasons that you would expect, especially those who've worked on this type of project before, there's information overload. You have nurses and physicians. We are responsible for many patients. We're getting data sent to us all the time. So it's hard to parse out, well, what's important, what's not important. But really, what's something that I would say that wasn't necessarily obvious to us when we first started this project, and is hopefully, I mean, obvious to everyone now who have been involved in the project, is there was a lack of a shared mental model around what is someone, like what does it mean for someone to deteriorate? So if you're a seasoned ICU physician, um, deterioration might mean something very different to you compared to, let's say, a nurse who's been working for the last 2 years. Um, Both perspectives are really important, and especially if the nurse is responsible for actually being at the patient's bedside the entire day, it actually is very important to factor in, for example, the nurse's mental model for what deterioration is, even if it's different from that of the ICU physician. And we found that there just often wasn't that shared definition. Sometimes there's friction amongst the team members. The nurse might escalate, and the physician might think, "Oh, that's not really deterioration." And then often what happens is you miss these opportunities for collaboration that actually is very important. So for those who are familiar with workflows in the hospital, you might know that often it's kind of hierarchical. You have this workflow where you have physicians who we see the patient every morning, we assess the risk of the patient, we assess how well they're doing, we assess the risk of the patient getting worse, and then we let the bedside nurse know what our plan is. We put an order in the electronic health record. Sometimes we have to talk to them in person, often we don't, and then the nurse executes on the care plan. So this is that traditional hierarchical structure. Um, when we first started this project, we already knew that we wanted to use predictive analytics, machine learning in some way, but we were purposely very open-minded in how that capability would be deployed. In fact, I still don't like to use the term deploy AI, because I think of AI as just a feature among many features, and really what you're deploying is that intervention. So we were interested in deploying an intervention that could help solve for some of these issues around lack of a shared mental model, information overload. And we went back to standard process improvement. So this is a book that I recommend anyone who's interested in quality improvement to read. It's called The Improvement Guide. I think it was published decades ago, but there's so much wisdom here. And there's actually a page at the very end that just lists all the different ways that systems can be improved. Um, and I just highlighted the ones that what we thought at the time were actually very relevant to how we might improve a workflow or model that would help physicians and nurses work together. So things like if you could do tasks in parallel, if you can somehow facilitate an agreement rather than conflict, share risks, standardization, things like that. Notice there's nothing here about AI. But what we did think about is like, if we had a prediction or classification capability, how can we actually make these things possible? I mean, in an ideal world, you can do all of these things, right? But it's not possible because it takes a lot of time and resources to create a system that has all these features. But if we had AI, can we make some of these features possible? What we then did was we did a key drivers analysis, which then allowed us to identify two specific key drivers we thought were critical to creating a better workflow, which is something that allows for continuous monitoring of patient's clinical status rather than the every 4-hour nursing checks or every 6-hour nursing checks. And then that importantly, you have that objective shared mental model. Can people actually arrive at a shared definition for what it means to deteriorate and why that's important? This is the conception of a new type of workflow that we wanted to build, a collaborative one where the physician and the nurse are actually on the same page. They're able to collaborate as partners rather than purely in a hierarchical form. And where the AI comes in is what if we use the AI to send the same information to both the physician and the nurse, so that the nurse is empowered in some way to at least bring things up to the physician, not based on just the nursing assessment, based on the AI assessment as well. And then having a standard where you kind of, it's like a forcing function to have the physician and the nurse talk to each other. So that's basically the intervention that we wanted to design that we're evaluating that's enabled by a prediction model. Identification of the task of the model. So this goes into just some standard processes we created to implement AI. We thought about, well, if we were to use a prediction model, what are the requirements to either build or select a model? That means selecting the right prediction task. So clinical deterioration is such a general term. There are all sorts of, quote unquote, clinical deterioration models, but I think we need to be very intentional about identifying, well, what exactly is the prediction task? Because it could actually vary depending on which model you use. And for us, there are two requirements. One is that the outcome should reflect an outcome that's useful to the user. So for example, if our goal was to prevent unexpected deterioration and our goal was to create this workflow where we want the nurse and the physician to talk to each other, then we were wondering, well, what would get them to do that? Like, what's a thing if I were to tell the nurse and the doctor what happened to a patient and when would it happen that would actually make them feel like, okay, well, we should talk to each other. It can't be something like the patient's going to die in an hour, right? Because in that case, then I mean, that's a very different clinical scenario that, you know, often is not as intervenable. It probably also shouldn't be the patient might go to the ICU 5 days later, because in that case, things happen, you know, in 5 days, so you can't really do anything. So we actually settled on something that is basically, like, the patient's probably going to be sicker, and we actually, and I'll mention this later, in the next 6 to 18 hours. So not quite 5 days, but not in an hour, so that we actually can, this workflow makes sense. And we ended up choosing the Epic deterioration model. This is back again in 2019. So it just seemed like the most pragmatic tool that we had. And some of you are already aware of the Epic model, and they trained it across 300,000 patient encounters. And for them, the model actually predicted rapid response events, ICU transfers, as well as inpatient death. And I'll just actually just table that last outcome right now, and I'll bring it. I'll come back to that later, because I'll talk about how we thought that might not have been the best prediction task for us. So this is just quickly showing you what the model did. I think Epic is probably coming out with an updated version, although I think right now this is still the model they have. It's an ordinal logistic regression. It calculates the composite outcome of RRTs, ICU transfers, and codes. It pulls data from Epic, about 20 clinical indicators, and updates the score every 15 minutes. I'll talk a bit about how we validated the model. So of course, as this group I'm sure is very familiar with, you have to validate the model with your local data set for you to make sure that it works and understand the performance for your patients. So we validated it for Stanford patients. This was back in 2020. The outcome, so the validation outcome we used was a little different from the one that Epic did, because Epic, they actually, when they advertised their model performance to have an AORC of, I think they said like 90%. I mean, what they did was, I think they looked at the composite outcome of death, ICU transfers, and codes. I don't think they had any lag time. So I think they included, like, if a patient had a score and then they died 2 hours later, they included that observation. For us, that wasn't very useful, because we didn't care. I mean, there could be a model that's really good at predicting someone's going to die in 2 hours, but for us, that's not something we needed for that workflow we created. So we actually constrained our validation outcome to just ICU transfers and RTs, because those were the two things that we actually were trying to prevent, or at least improve on. And then they had to happen within 6 to 18 hours after the prediction was generated. And that was a time frame that we arrived at with feedback from our clinical partners. And we did it on over 6,000 acute care encounters at Stanford. This is back in 2020. And the performance, as we expected, was not nearly as good as what Epic advertised. And you can see the ROC curve here. It's not great. The PR curve. And then we ended up deciding on a threshold of about 0.65, which got us to at a PPV and a sensitivity of 20%. Now, this gets into the design, kind of the workflow development part of the project. What workflows can be enabled now? So now we have a model. We have a model that has a PPV of 20%, a sensitivity of 20%. Probably not great, right? But at the same time, we are saying that if a patient is flagged by this model, there's a 1 in 5 chance that they would experience an RRT, a code, or an ICU transfer in the next 6 to 18 hours. That's actually not that bad. When we talk to other clinicians about this, or a nurse, they're like, yeah, I mean, honestly, I'd want to know about that. I mean, if I told a physician that your patient is going to go to the ICU, there's a 20% chance they're going to go to the ICU, you should probably talk to the nurse. Most did agree that that is reasonable. So that's the kind of thing that we are now designing for. And the deliverable here is that set of workflows and applications that are ready for deployment. Let me just quickly show you what we built and deployed. So this is the intervention. The intervention was basically, this is an Epic, now called an OPA. It's like an alert that pops up in Epic. We also had a thing that delivered an alert to your mobile device. And you can see the communication, like what we actually are having the teams do. And this was all tested and designed with nurses and physicians. You can see that on the top, we say risk of clinical deterioration alert, and the language here, greater than 20% risk. So that was actually really important, because I mean, if your fellow clinician told you that, you'd probably respond. So we wanted to mimic that type of communication, except that this has come from AI. And the intervention was actually something called an SBAR, which is a standard way of handing off information between teams in critical situations. And we chose this because the nurses were already trained in SBAR. That stands for Situation, Background, Assessment, and Response. So it was important for us to create a very standard way for a nurse who might be receiving this alert to then have a standard way of conveying their concern to the physician that's objective, in a way that the physician kind of needs to respond to, even if they don't necessarily agree with the assessment. And then what the next step is, actually the nurse and the physician has to do a shared checklist. They have to go through a shared checklist in a huddle. This was, in my opinion, this was probably the most important part of the intervention. And you can see actually what's in this huddle here because it's documented in Epic. What it is the nurse presents the patient, the physician might say, I mean, if it was a clear false positive, the physician might say something. Actually, in this model, there are a lot of patients who are just demented or they were delirious, and their GCS was measured as 8, but they weren't necessarily getting sick. So we saw that was actually a very common false positive. But if it wasn't a false positive, then the nurse and the physician had to discuss the nursing perspective, but also importantly, if let's just assume that the AI is right. Let's assume that this patient will go to the ICU. Let's brainstorm some possible reasons why they might. And that one question we thought was actually the most important thing to discuss, because what happens then actually, and I've done this so many times with myself as well as my residents who sometimes are skeptical about doing this, but then when they do it, they're like, oh, wow, like I really am glad I talked to the nurse about this, because the nurses are going to pick up on things that you as the physician who's sitting in your workroom, like going through your lab and reading, you're not going to be able to pick up on, like the patient's feeding tube is almost being pulled out, or like their head of the bed is not quite elevated. Like these are the things that we don't think about, nurses do, and they're aware. If that's situational awareness that the patient is sick, that could make or break. That could really make a huge impact on the patient's care. I'll just quickly show you some examples of how we trained our staff. I mean, we had to do a lot of things like create FAQs and best practice scripting. I think scripting was very important. We all think that we're really good at talking to other physicians. We're not, like we actually we have to practice how to do handoffs, how to consistently deliver the right information, especially when it's between nurses and physicians. We did see actually a pretty initially sustained increase in the completion rate of huddle. Now it's actually still, so this thing is still live in the hospital. Our completion rate for the huddle is still above 80, it's actually above, yeah, it's about 80%. And part of this is really because it's nursing driven. So that was a key, I think, aspect of our success. The nurses are leading this, they're driving the huddles. Physicians may or may not agree with doing it, but the nurses are going to do it anyway. And that, I think, allows us to be successful in the adherence of this project. So when we surveyed initially this for this project, the nurses loved it. They actually, a lot of them felt like this was adding value. You can see some of the results here. And I think a lot of them just felt like they could talk to doctors more. They were more empowered, especially the newer ones. And we thought that was very, very powerful. So let me actually then just finish with a discussion of our paper, which I know is actually the core topic of this talk, which is when we then actually evaluated the effectiveness of this intervention. So this was a paper that we published last year, and I just really wanted to give credit to Dr. Robert Gallo. He's a physician and led a lot of the analysis for this paper. And I had hoped that he would be able to join today, but he had a conflict, so I'll have to present on his behalf. So this project, as I mentioned, was a QI project, and we did a lot of QI style evaluations. We surveyed folks, but we really did want to see, look, did this actually improve an outcome? Was there an effect of this intervention? So not of the models. I just actually be very, very clear. The intervention was the entire thing, the model-enabled workflow. So what was the effect of the intervention on our primary outcome of interest, which was inpatient codes, rapid response ICU transfers? So you can see here. And then the design and methodology was we actually used a regression discontinuity design, which I'll discuss later. Just taking a step back, and I think this might be interesting to this audience here, as you probably have all recognized, there's a really important need for rigorous, but also pragmatic study designs. Of course, we'd all want randomized clinical trials of every intervention we implement, but that's really not that practical. We have these traditional pre-post, run chart style evaluations, but as many of you know, they're very vulnerable to confounding, especially secular trends. So and I know there are some experts in this talk here on this kind of stuff, but things like any type of quasi-experimental approach that where you're able to evaluate effectiveness, maybe not quite at the level of our randomized study, but definitely better than not having one at all. that you can actually conduct and at scale, I think that would be such a valuable thing for not just AI evaluations, but any evaluation of interventions. I'll quickly just talk about the design here, because I think this was one example that we used, one approach we used that we thought actually worked really well for our project. And really, I think many projects where there's a threshold, where there's a prediction threshold that actually, I think, is the case for many AI projects. So we use something called a regression discontinuity design. What that is it uses the prediction threshold, which is the threshold at which, let's say, the score, if you have a prediction model and if the score is above, let's say, 65, then you do something. If the score is below 65, you don't do something. So 65 is the threshold I'm describing here. So it leverages that threshold to create kind of a natural experiment, comparing patients who are exposed versus not exposed. Because when you do an effectiveness evaluation, your goal is to essentially create a counterfactual, right? Like ideally, you want to compare to someone exactly like yourself, but who didn't receive the intervention. Because that's very difficult to actually simulate in real life, what you could do is assume that, well, if you have a patient whose score was 67, who got the intervention, that patient probably is pretty similar to the one whose score was 63, but did not get the intervention, right? Because the score is, I mean, they should clinically be somewhat similar, somewhat arbitrary that we just gave the intervention to someone above 65. So that actually creates kind of a local randomization effect. And you can actually leverage that to use some statistics here. And I won't go into the details, but essentially you're looking at if there's discontinuity in the intercepts of a line and seeing if there's actually an effect because of that intervention that was delivered only for patients above a certain threshold. There are a couple of statistical assumptions here, and I can go into this. I'm sure Dr. Escobar will talk about this later, but there are some assumptions for this analysis to be valid, and we did test for all of this in our paper. So really the takeaway for us was that when we used this approach, we actually looked at almost 10,000 inpatient admissions. But if we only looked within the analysis window, it was about 1,000 admissions. We found that there was this intervention was associated with a 10.4% decrease, absolute risk reduction in the primary outcome, which was ICU transfer, RRTs, and cardiopulmonary arrest. And then again, like I mentioned, a lot of the assumptions that would have to occur for this result to be true, we did test for those, and they were in fact true. I'll end with just some overall thoughts, and I'd love to have a discussion about this, which is we saw that there was an effect, which is great. But the key question is why, and how do we replicate this? And what do we learn about not just this project, but how AI impacts clinical workflows and decision-making in general? I have 3 hypotheses here, and I'd love to have a discussion about this. One is you have an AI that definitely can change clinical decision-making thresholds. So if you're a seasoned physician and you probably are very used to patients being very sick, you would need some kind of external input for you to feel like you have to do something when maybe at baseline you wouldn't do something. Maybe you wouldn't feel like you need to talk to a nurse, for this type of patient. But if something is it's a forcing function to make you do it, you might do that. So I think that's definitely one way AI could change the work system. Increasing consistency. So the AI is going to be wrong. I mean, in this case, we know it was wrong 4 out of 5 times, but at least it created a consistent intervention, which was the huddle. So even if 4 out of 5 times the patients for whom there was a huddle did not go to the ICU, at least there was a huddle, right? At least you have a consistent workflow now of a physician and the nurse talking to each other and going through a checklist, which at least for our nurses was actually very valuable. And for physicians, I think when they got into it, it was also valuable. And then number 3 in this case, and this is our core argument, is it actually increases the number and diversity of individuals making clinical decisions. In our case, the AI was not necessarily telling people what to do, but it was acting like a mediator. It was a forcing function to enable collaborative conversations that otherwise may not actually have happened. And I think what's really interesting is if you could measure these mediators and then see are there feedback loops and aggregate behaviors that emerge when you have nurses and doctors talking to each other enabled by AI, like how can that create a culture of safety and an overall more effective system? So key takeaways, number 1, to improve care delivery, AI can be leveraged as not necessarily the intervention, but as an enabling feature of broader care models. AI certainly can be done to help decision making, but I think having it to really mediate collaboration and communication could be a really effective way of deploying that technology. And then finally, having a rigorous approach to evaluate real-world implications that are pragmatic, but also valid. I think that is very important. And also just to emphasize, like this is actually very different from the work of monitoring the performance of AI models, which I know many health systems do. That's very important as well, but that's different from evaluating the intervention that includes some AI models, but other components. So I'll end with just saying really thank you to this group and really everyone who's been involved with this project. You can see their names here and there are more. I mean, projects like these are very multidisciplinary. So appreciate your contributions. And with that, I'm happy to stop here and continue our discussion.
Great. Thank you so much, Ron, and really appreciate. I like to say sometimes there's the fear that AI will put layers of technology between people, but in this case, I think you've really emphasized how AI can make us more human. Uh, driving those important conversations that are sometimes missed in the process of care. So that was really great. There are some questions in the chat, but I'm going to first turn to Gabriel, as a person who's been in this field for a couple decades, to lend us some of your thoughts.
Well, thank you, Vinny. And Ron, thank you for this really nice presentation. When I heard you speak, I was thinking, gee, these are all the things I wished I had done. But here's what I got out of your talk. And then I actually wanted to ask you some questions that are still plaguing us. So I think what you showed was how critical it is to think about the context in which these things occur. What's now clearly the thing in medicine because of the prevalence of EHRs, which is the workflow. If you can't get something into a workflow, you could have a cure for cancer and it's just not going to happen, right? So the carefulness with which you address that is really important. And then I think the issue of evaluation, which you really emphasized, is so important because for a long time, the literature has been dominated by this trying to change the C statistic. I'm sorry, somebody else is speaking, or so what I really liked about what you presented was the focus on implementation, which I think is always the big challenge, and evaluation as opposed to the predictive model itself, because predictive models basically have become a commodity and we shouldn't be obsessing about them and chasing C statistics anymore. I think to me, the most important aspect of a predictive model is that it takes a bunch of people's thinking, which is about implicit risk, where one person thinks this patient's going to crash, another person thinks maybe, but once you have a prediction out there in front of you, you may not agree with it, but at least somebody has made it explicit. They've sort of drawn a line in the sand, and it sort of forces the environment to rearrange itself around this new piece of information. So it's very clear from your presentation that you did achieve that goal. Now, I wanted to mention a few problems we had at KP and that we're still having, and I really wanted to hear your thoughts about them. So one of the issues is when I first was working to deploy our very first model at the second pilot site, and I first presented it to the hospitalists and ICU physicians, some people got hysterically angry at that presentation because they were really nervous, really unhappy, and the concern they said was, I already know this. I know which patient is going to crash. And so my response to them, well, if you know, how come the casualty rate is so high? When we look at patients who are transferred into the ICU, their mortality is so much higher than if they just went to the ICU from the ED. And I was just curious if when you started this work, if you experienced that. Now, the other three items, and then I'm going to let you answer my questions, that have been a problem. When I first deployed this at 2 sites, I actually spent most of my time not working on the clinical response because I was able to hand that off to a couple of enthusiastic hospitalists and the RRT nurse. And so the resuscitation part, they got down really fast. I actually spent most of my time dealing with end-of-life care and handling all the issues. And ultimately, when the AAM was deployed at KP, end-of-life care was one of the major drivers for the deployment, and the extra staffing that was given to hospitals, a lot of it was driven by the need to standardize end-of-life care across the 21 hospital system. And then there are two ongoing problems. So one is the problem of counterintuitiveness, which perhaps you guys are doing a better job at, which is in our system, if there's an alert, it's screened for you, then you go see the patient, and let's say you fix everything, so nothing happens. Whereas if there's a code blue, you feel like you're doing something, and then you write a long note and everything. So one issue is, how do you handle this counterintuitive aspect of these alerts? And then the other issue, which is still a big hot issue at KP, is what is the documentation standard for a physician's response to an alert? Because the fact is that once you've created something, especially if like what you have, there's a BPA out there in the EHR, that's discoverable. So there is both individual liability as well as enterprise liability from whether or not you document an alert and maybe do something or not do something. So I'd like to hear, I'm just going to repeat my 4 questions if you could cover them. So one is the initial freak out response by some physicians, the issue of end-of-life care and how you guys are handling it, documentation, what are your documentation standards, or are you seeing unhappiness about that? And then this issue of the counterintuitive nature of alerts. But thank you so much for a presentation, and I look forward to hearing your answers.
Thank you. I would say the answer to all 4 questions is yes. But in all seriousness, I mean, I think there's so many of these elements blend together, right? And we absolutely encountered everything you're describing. Maybe I'll start with the initial point you made, which I find such a great way of describing, I think, what we're also trying to achieve here, which is that the AI is not necessarily telling something that the physician or even the nurse might not already know. That wasn't our goal. But the goal was to just establish a thing, like just establish an opinion. And for, I think, anyone who's practiced medicine, we don't really, a lot of times we really don't know. Like we hem and haw, maybe the internists do a bit more than the ED physicians, but there's just so much back and forth. But often when there is an opinion that's already established, then at least gives you a basis. It gives you a foundation to which then you can then discuss. So what we're solving for is not so much creating new information, but it was to have a forcing function for a discussion, because we just thought that at the end of the day, this was a communications project. And this kind of gets to, how do we engage our staff? Because you're like, when we first presented this as, oh, this is like an AI implementation, I think most people just didn't really care that much. I mean, this was before all the AI hype, GPT. I mean, this was when AI was kind of cool to a couple of people, but for your average, especially your average nurse, they just kind of rolled their eyes. And, and definitely even, I mean, we're a teaching hospital, so we have a lot of residents who come and go. I mean, some of them were enthusiasts, but really most of them were just like, all right, it's another AI. Like, they don't really get it. But when we framed this as, look, this is a communications project. This is a project to improve physician-nurse collaboration and communication. I can tell you that reframing alone, at least for the nurses, completely flipped this upside down. I mean, like nurses, this is such a pain point for nurses to be able to feel like they can adequately communicate with their doctors. We didn't even mention this was an AI project. It was like, oh, we're just trying to improve collaboration. Like, who doesn't want that? And actually, for the physicians, that too was something that really resonated. I actually remember very clearly that I had a conversation with a resident. I was on service and I was telling them about this project a couple of years ago. And I remember saying, I used AI a couple of times. Again, this is before ChatGPT, and she was like, okay, like you clearly wasn't that interested. And then I talked about the huddle, and she was almost like, oh, okay, so this is just like this is a communications project. And I was like, yeah. And she's like, oh, okay, I get it. So I think just framing the project in a way that resonates with the people who are using your tool, which often is not the same framework that the people building the tool has. I think just acknowledging that is very helpful. And then picking the language and really, I think it's not even just the language. It's actually how we build the project and how we implement it, doing it in such a way that just really resonates at the core, with the people who are doing the work. So for us, it was communication, collaboration. And I think that really helped a lot in the uptake and adoption. I think the second thing that we were, I mean, certainly yeah, like we definitely got a lot of doctors to say, like, oh, like this is not telling me anything. I already know this patient's sick, like all the same feedback, right? And I mean, I can say at least so I often try to model this by, I'll have my residents do the huddle. And I will say this is particularly helpful for us because we have trainees who come and go. So I think that standardization of having nurses talk to them is probably even more helpful for us than, let's say, in a care setting where you have a hospitalist who just is super familiar. They already know the nurses. For us, it's actually the nurses and the residents don't even know each other. They don't even know each other's names. They haven't seen each other. So it was actually very helpful for me to just say, look, we're going to do this huddle. Let's walk over to the patient's bedside, or it could be on the phone, but ideally to the patient's bedside. Let's get the nurse here. Let's see their faces. And this speaks to, I think, that counterintuitive nature of these interventions, right? Because you're right. We're not pushing Lasix, like, getting BiPAP on, all that stuff. But we are actually doing something. But like, I actually think this was important. It wasn't just we got the alert and we're supposed to just assess the patient, because that is often, I think, very, I don't know, for people, they just feel like it's not really a thing that they're doing. But here, what we're doing is we're having a meeting, we're having a huddle with a nurse. A huddle is almost like an intervention, and it's actually kind of an intense thing. Like it takes 4 minutes, it's very short. But I mean, if you do it well, like it's a huddle. You as the physician, you're kind of managing it, or the nurse might be doing it. You have a very standard checklist. It's almost like a timeout before you do a surgery or something like that. And then yeah, you just like, oh, what's going on? What's your perspective? What are the reasons? And it's pretty regimented. So it actually feels like you are doing something. And then often you will find things that doctors miss. And I think it just really takes a couple of instances when a physician's proven wrong that they'll really get into it. So like a lot of times, like, you have a patient who's so common, someone who's pneumonia, who's older, maybe has a little bit of dementia, their score's high, and then they're coughing a lot, and you go to the bedside and they're just like laying flat. And for us, actually, inpatient codes, like the most common reason is aspiration. So, and these are just things that if you're a physician, you could be the most brilliant internist or ICU doctor, you can know everything there is to know about treating sepsis, whatever. But unless you're just there at the patient's bedside all the time, you just wouldn't think about these things. But when you're there and the nurse tells you, oh, by the way, the patient has been like, there's been more secretions, I feel like I've been suctioning them a lot more. Then you're like, oh, okay, all right. And then it becomes a clinical conversation. So I think that helped address some of the issues you described. I think I've included some of your questions here. I might be missing one of them. So can you remind me?
Well, just one little add-on. Do you have dedicated staffing for the RRTs? Is there like a dedicated out-of-the-count RRT nurse, or are your nurses sort of ad hoc on the RRT?
There is a dedicated RRT team, but that was not the team that huddled with the physician for this intervention. This intervention was directed at the bedside nurse. The intention was to prevent an RRT from happening. I mean, assuming it wasn't needed. But we do have a dedicated RRT team.
And the other two questions I had was, sometimes you get an alert and what you realize is this patient is going to deteriorate, but maybe this patient isn't sure that they want to be rescued, right? So
that's right. Yeah, at the end of life. That's right. Yep. Yeah. Actually, so that's a great. So actually, in our checklist, one of the interventions actually. So basically, the checklist is the S-bar. Nurse talks about their perspective. Physician does theirs. We brainstorm possible reasons for deterioration, and then we actually do also brainstorm interventions. They're not physician-oriented. It's not physician-oriented language. It's actually a nursing-oriented language. So we don't necessarily go through the entire care plan, but we do things like say, oh, we have to make sure the head of the bed up. Actually, goals of care conversation is a very common one. So yes, that is actually what happens a lot that makes the nurses really appreciate this, which is that sometimes, I mean, even if we all feel like even if we all know in our hearts that we should have a goals of care conversation with the patient, sometimes it just doesn't come up, or because we're busy and something else takes up our time. So actually, one of the things we discuss here is what's the goals of care? Do we need a conversation? And if so, let's have one. And actually, that has helped a lot in circumstances where we change the patient's code status as a result of this conversation.
And then the last question, which is also related to this, of course, is this issue of what is the expectation in terms of physician documentation following a huddle?
The physician doesn't document. It's all nursing driven documentation. So they documented a flow sheet. There's no I mean, if there's a goals of care harmonization or intervention, you of course incorporate that into your note, but there isn't a specific note that you need to write for each alert in addition to what the nurse is documenting.
Okay, so you basically made, I think, a wonderful strategic decision to not require the physicians to.
Yeah.
On the other hand, surely you must advise your physicians that sometimes you probably do want to document, right? I mean,
Yeah.
but it's
Yeah, I
not
mean, I think they
mandatory.
would document the progress. I mean, they had a conversation with the nurse and they made a decision. They should document that. But to your point, that's very difficult to. I mean, that will be the bottleneck. Whereas for nurses, it's not just the documentation, but just the implementation of the workflow. Like we actually strategically chose to have nurses drive that because one, I think the nurses actually found the most value from it, and two, just because of the nursing operational structure, it's easier assuming you have the buy-in from nursing leadership to actually scale a workflow like this.
Thank you so much. I really loved your talk. Maybe we should let other people ask questions because I know there's a lot of them.
Sorry, I'm muted. Thank you, Gabriel. Well, let me see if there's anybody who wants to put their hand up, or I can run through a list of questions that I'm seeing in the chat. Let's just go quickly here. Are you able to define clinical deterioration? It seems to imply a longitudinal aspect.
In our case, it was defined by the outcome, which was RRTs, codes, ICU transfers. I mean, there is a philosophical answer to this too, which is just a patient getting worse, and we can argue what that means. And I would say that is actually what we're trying to prevent, but the objective way we're measuring would be those three outcomes.
Was your validation based on prospective or retrospective data?
The initial validation was done retrospectively. Now we're actually revisiting this, and we are, well, it's still a retrospective, I guess, as we're looking at all the data that we generated over the last couple of years. I don't think we're actively prospecting validating in the sense that there's like a real-time feedback, based on every RT. So we're not doing that. And then the validation itself was
prospectively collected. Sorry, prospectively collected retrospective analysis, I think is right. Like
prospectively
you're
collected,
using
retrospectively analysis.
data,
Oh, yes.
but
Yeah.
you're choosing to analyze, right? Okay.
Yeah.
Can I ask a follow-up? Can I ask a follow-up about that real quick?
Sure.
Yeah, sorry. So so we've been having the same issue with Epic-based models in terms of validating to the definition that we think would be more appropriate compared to what they traditionally validate. And so I think the challenge we've been facing is that you can't, like when we have a retrospective data set, it's often hard for them to file the scores for that retrospective data set versus you'd have to run the model prospectively to see what it's scoring in order to really validate it against what you're interested in. So I'm wondering how you sort of address that challenge.
Yeah, silent deployment. That's the way around it. You're right. I mean, Epic has these. Sometimes they'll have these packages. They're really clunky. I don't know if they fixed it since we did it, but that was actually exactly the problem we had. It was very difficult to say like retroactively generate scores for patients a year prior. But what you could do is you just turn the model on, right? You turn the model on, you have it actually generate scores for a couple of months, and then now you have data that you can then match with your outcome.
Ron, have you thought about changing the threshold?
I mean, I would like to change the model.
Improve sensitivity.
Yeah, I mean, I think what we are realizing, we suspected this when we first implemented this, is that 20% PPV is not. It could be better, and we know we could do better. So I think just because it's not even just the PPV being lower, but it's the systematic bias that you are experiencing with certain populations. So as I mentioned before, in this particular model, we've given feedback to Epic about this because the clinical indicators include a bunch of nursing documented measures like GCS, mental status. It really creates the systematic bias to create false positives for patients who have poor mental status because of chronic condition. aka people who have dementia, people who are delirious, and that's very common, as you can imagine, in the hospital. So what happens then, you really get this automation complacency where 20-year-old guy he fires, and you just kind of assume, oh, it's because he's demented, and probably is, but what if it's not, right? So it actually really impacts, I think, the performance of the intervention. I think there are definitely, I mean, I think there would be ways to create a better model that accounts for that. So that would be my recommendation.
Maybe this gets to that. Were you able to study model failures in practice? You've identified some of the biases that flagged
Yeah.
with false positives, but what about false negatives?
We haven't, I mean, now we have a data science team at the hospital, and I know they're looking at some of this stuff. So I think they are looking at it a bit. I mean, when we looked at it, we didn't look at it as rigorously as probably we should have for the catch the false negatives, because that requires, really getting in and seeing, well, what could they have missed? I mean, intuitively, just also from my personal experience, I mean, there are definitely false negatives, and just it's just because of the lack of the data inputs that goes into the model. I don't know if there are any specific categories that I can think of. The one that's most obvious to me is the false positives from the mental status, like from chronically demented patients.
Okay. Including caregivers' observations, have you found, I mean, you showed kind of a little field
Yeah.
where some, decision making or, differential diagnosis kind of thing was being done. Anything beyond that?
No, we tried to keep it simple. There was discussion very early on. It's like, do we tell the patients about this? We tell them that they're part of some AI, they're using some AI tool. So we did have those conversations early on. I mean, ultimately, the decision was to keep it really just within the provider group, because at the end, this really wasn't an AI deployment. This was this was just a QI project to help doctors and nurses talk to each other. There was some AI to make it happen, but I think the framing of it as just a communications intervention was just easier, I think, and it probably was more reflective of what we were doing. And I think it just would have created noise, I think, if we had tried too hard to, you know, create something that's artificial. Whereas I think we actually were very much of the philosophy of, let's just get the people to do what they were going to do anyway, but just help them out. I mean, caregiver observations, I can definitely say that caregivers liked that doctors and nurses talk to each other. So whenever that happened, I think, this is just personal, I don't have data showing this yet, but I mean, from my personal observations and talking to nurses, definitely, I mean, caregivers love it when they're seeing the action. So when that happens, I think almost universally, it's a good thing.
Okay, maybe just one more question here. How much of an impediment was it to have multiple individuals' diversity of views and decision making versus improvement? Is there a delay due to the huddle?
Was there a delay in the realization of the outcome because of the huddle,
or just in the kind of the ability to intervene on a patient? Like, was the huddle an impediment to,
Oh, I see.
treating
I
a patient
see.
effectively or in a timely fashion?
So I think for us, the huddle actually was the intervention. I think I understand the question, which was, well, if did the huddle delay decision making, let's say, by the physician? I would say most likely not, because there was nothing in the workflow that said the physician had to wait to huddle before doing anything. I mean, if a physician felt like they needed to order something, they were going to do it. So we didn't measure this, but I doubt it, just based on how we implemented it. The huddle, though, to us was the intervention, because we didn't actually look at, well, what medications were ordered, and often there were no medications. Often it was just a discussion and situational awareness. It's really difficult to measure that as an entity. So I guess I don't really know what the answer is. But I think that's also just kind of like, I think your implementation design, like we really wanted it to be as natural as possible. There was no regimented set of rules where you had to do this, you had to, deploy this bundle, because we just knew that the reasons why people deteriorate are so diverse, and we wanted to trust the people who are taking care of the patients to make those decisions. What we really could do was just making sure they talk to each other, and that's really all there was.
Great. Well, let's see. I want to close this out by making a couple announcements, which are in the chat. The next Health AI Hub will be on Monday at 4 Eastern. where there'll be a presentation from Patrick Wingo at Elion talking about how clinical AI assistants, clinician AI assistants are reshaping practice, followed by AI in Action event with Dr. Hakeem Adeniyi talking about FQHC settings based on experience as the Chief Clinical Officer at the Sacramento Native American Health Center. So the links are there. These sound very interesting in terms of real-world implementation. I guess just as a takeaway, Ron, I think just really, really interesting. I think you're short selling yourself by saying it's not an AI project. It's just a communications tool, because I think you have brought attention or light to a mechanism through which AI will act and can act effectively. So, I don't think all of AI has to be the super fancy whatever chatbot that pulls in all your information. You know what I mean? There are lots of these very, very potent opportunities where the lift does not seem that huge from either a technological standpoint or in some cases a change management standpoint. I do think also kind of the ability to make us more human is a huge driving part to do something we should do and we want to do, but where we're just not standardized around that. And you've displayed how that kind of focus really drove a beneficial outcome. And then finally, I would just say there's a lot of questions about whether a model that is kind of moderately or low moderate performance, you didn't have a specific AUC there, but I would put that, like, it looked like it was in the 0.6s or something. Can that actually produce a beneficial outcome? Because people are obsessed with AUC. And I think what you've clearly shown is yes, it's not really just about the model itself. Of course, you would and we would love to have a more efficient model, more precise model, so that we can target these patients better. But even a low moderate performing model can actually drive an important clinical outcome if we deploy it in the right way. So thank you for sharing those insights. Thank you all for attending. And please feel free to follow up with Ron if you have additional questions. Have a good afternoon, everyone.